much, Director of Press, Office of the Secretary to the Government of Nigeria. Uh, Distinguished ladies and gentlemen of the press, I want to once again welcome you to the National Strategic Cold Store of the National Primary Healthcare Development Agency, which is an agency under the Federal Ministry of Health. As you earlier observed, we do have up to 3 ultra cold chain equipment that are fully functional in good working condition. These ultra cold chain equipment each have a capacity of 700 liters. So total capacity available to store the Pfizer BioNTech vaccine is 2,100 liters. For the first 100,000 doses of the Pfizer vaccine that we're going to be receiving by the end of this month or early February, the total requirement is 500 liters. So we have more than required capacity. So some of the information going out there that we do not have the capacity to store the 100,000 doses is not correct. So today's visit is really to demonstrate the availability of the ultra cold chain equipment and to emphasize the fact that we're working together with our development partners to roll out a comprehensive deployment plan that will ensure that we leverage on the experiences of the polio eradication program. All of the really amazing work that Nigerians have done, the frontline health workers that helped us to get Nigeria and Africa certified as wild polio virus free just last year. All of that effort will be tapped into towards the deployment of COVID-19 vaccine. We understand and acknowledge that it's not exactly the same vaccine, different scenarios, but the same types of principles around coordination, micro-planning, trainings, building capacity, community engagement. Those are the same principles that will help us be successful. Only last year, we had, in October actually of last year, we had a campaign that reached 23 million kids under 5 years of age. So that gives us confidence that we'll be able to reach Nigerians over the course of the next 2 years, up to 70% of Nigerians. However, we are mindful that this has to be predicated on real-time issues. For example, the vaccines are not even here yet, so you cannot start the countdown until we have the vaccines. The first tranche of vaccines will be coming by the end of January or early February, right? 100,000 doses is just a drop in the ocean. It's not anywhere near what we require, right? So the clock starts ticking when we have those quantities of vaccines that can actually begin to make a huge dent in terms of coverage of Nigerians. We're also mindful that we still have to do a lot of work to overcome the vaccine hesitancy that we're already seeing, the misinformation, the conspiracy theories around the COVID-19 vaccines. And we do not take for granted that all Nigerians understand the principles around vaccine production. That is why we know we have to do the hard work. It's not enough for us to offer the vaccines to Nigerians. We also have to do the hard work of sharing information, educating Nigerians about the vaccines, how they were produced, the facts that they are safe, and all of the measures that the Presidential Task Force, the Federal Ministry of Health, and National Primary Healthcare Development Agency, working with the NCDC and other line ministries, are doing to make sure that NAFDAC certifies that these vaccines are safe and effective before they will be deployed. No vaccines will be administered to any Nigerian without NAFDAC, the regulatory organization, certifying that they've gone through all of the dossier, they've done the necessary tests, and they can confirm using reliance mechanisms, using WHO data to say, yes, these vaccines are safe for Nigerians. I want to reiterate that the responsibility of taking that decision to vaccinate Nigerians is the responsibility of government. It is a sacred trust that we do not take for granted. It is something that we're going to be doing very diligently. But we know that all those concerns that are being raised are not just out of mischief. It's because people don't understand. So we are going to continue to work hard. We're going to be working with traditional leaders, educating them, because they are the gatekeepers of the communities. They understand how to communicate. Our religious leaders, our community-based organizations, opinion leaders, political leaders, because they are the representatives of the people, and they can communicate even better than ourselves, right, around how safe the vaccines are and what we have done to make sure that all the boxes are checked when it comes to making sure that Nigerians have access to these vaccines. But working with our partners also, we want to make sure that the processes, the logistics, the operations that are required to get to the last mile are actually taken care of. We do not take for granted that this is going to be an easy task. We know that difficult days are ahead, but we also know that this is a responsibility. And drawing on our lessons of the past, we want to succeed. And this is why everybody has to be on deck, must have all hands on deck to make sure that we deliver these vaccines, despite all of the challenges that we will be facing. So thank you very much for all of the questions that you've raised, all of the work that the media is doing. We are all in this together. I like to say that we're one team, we're one Nigeria, and we have to focus on how we can deliver the vaccines to all Nigerians so that all Nigerians will be protected, so that we can, once and for all, eradicate this disease. Eradicating this disease means eradicating disease globally, not in just one community, not in just one country. It is a question of making sure that as one global community, we're able to ensure fair and equitable access to the vaccine. As we all know, the virus does not know borders. It doesn't know Nigeria from Cameroon or the Benin Republic or the United States. It just flows across the lines of least resistance. So we must work together as small communities, as states, as local governments to make sure that we eradicate this virus. Countries have to collaborate together to make sure that it's not a disease that is left for only Africans because we don't have the vaccines. We have to work together to make sure that the vaccines are also available to Africans, to low and middle income countries, just as the developed countries have been able to procure them. It is only when we're able to do that that we will eradicate the virus globally. There's no such thing as a partial eradication. We can only talk about total eradication, and it's in working together that we can quickly stop this pandemic. So thank you very much. In terms of the facility, so this is not the headquarters of MPHCDA. The headquarters of MPHCDA is actually in Garki, right? That is where the offices are. This is just the National Strategic Cold Store where we keep our vaccines and some of the commodities that we use in the primary healthcare centers. We have similar structures in the 6 geopolitical zones where MPHCDA's zonal offices are. Apart from the 6 geopolitical zones, each state also has a cold store that keeps vaccines and other commodities. So yes, we do have such facilities replicated, of course, in varying dimensions across the zones and the states. In terms of the distribution of the vaccines, I want to reiterate that our focus in terms of how the vaccines will be distributed will be prioritizing the health workers and the support staff of the health workers that work in the front lines, in the isolation centers, support staff that do cleaning, for example, the sweepers. We're also prioritizing strategic leadership. We're prioritizing the elderly people, especially those that have comorbidities. And then we're also prioritizing other first responders. Now, in terms of how many doses goes to different states, this will clearly be determined by the number of health workers that exist in those states working on the front line. We're going to be looking at the epidemiology of the virus. So, for example, where are the hot spots? Where are the hot spot LGAs? Where is it that the outbreak is raging? Those are the places where we expect that we'll be able to deploy the vaccines. Okay, so the duration of, well, so as long as we keep the vaccines in the ultra cold chain, yes, they will continue to be potent. But once they leave the ultra cold chain, they can last only for about 5 days in normal refrigerators of +2 to +8. Then there was a question from AFP. The total capacity that we have here is 2,100 liters capacity. The 100,000 doses that we're expecting from the COVAX facility by the end of January/early February will be able to occupy only 500 liters. So what it means is that what we have here can take a little over 400,000 doses of the Pfizer vaccine. Now, you can imagine that these ultra-cold equipment are not generally available in this country. And as you move from the national to the zones, to the states, the local government, and the health facilities, there's a lot of logistics that is required. That requires building the capacity of health workers to do all of that very complex work. So the position of the Presidential Task Force and the Federal Ministry of Health is we will be focusing more on those vaccines that do not require this kind of complicated cold chain mechanisms, right? So the Oxford AstraZeneca types of vaccine that require +2 to +8 degrees Celsius are what we're going to be focusing on. We're also aware that in our conversations with the COVAX facilities, if at all they are going to be bringing additional Pfizer BioNTech type vaccines, they will be making provision as well for ultra cold chain equipment. That is sort of the package that will be coming from the COVAX facility. But most importantly, we know that it's easier for us to move vaccines that we are used to. Our routine immunization vaccines are stored at +2 to +8, most of our routine immunization vaccines, and we expect that since health workers are already used to managing those types of vaccines, those are the types of vaccines that we should be investing our resources into. Again, we acknowledge that in any country, there are people that are going to be skeptical about vaccines. The issue of vaccine hesitancy is not something that is local to Nigeria. It's a global phenomenon, and the ways to address them are similar. It will require health workers, scientists, not just offering the vaccine, but also doing the extra work to convince the populace on the safety of the vaccine, helping them to understand why they need the vaccines, not only to protect themselves, but to protect their loved ones and their communities, right? So quite often, health workers, medical experts, scientists like us are very dismissive of the cynicism and the skepticism of the general populace. But we really have to make sure that we do that extra work that is required so that people understand why they should take vaccines, why they feel that they are going to be safer, they'll be protected when they take these vaccines. It takes a lot of extra work, but it is work that is really required, and it is work that we plan to put into the efforts of helping us overcome this hesitancy. If we do not overcome this hesitancy and we have pockets of communities that refuse to take the vaccine, then we're going to be here for a very long time battling COVID-19. So for us to be able to build herd immunity, we need a situation where community members are accepting of the vaccine so that we'll be able to protect communities, countries globally. So the hesitancy issue has to be approached from a local point of view, making sure that we use local leaders, religious leaders, community-based organizations to overcome this hesitancy, provide the right information, right? in a way that shows respect to the person who's asking questions. People want to be respected because respect is reciprocal. If you respect people and listen to them and not dismiss them, then they are likely to listen to you, and that is the approach that we're going to be using. We're going to be leveraging on the experiences of the polio eradication program. Now, early in the polio eradication program, we did not engage with community leaders, local leaders, religious leaders the way we were supposed to. We've learned from that mistake, and we don't plan to make that same mistake again. That is why with the COVID-19, we've engaged local leaders to try and communicate to their subjects, to their congregations, the religious leaders, so that they understand the whole principle around COVID-19 and why we are offering the vaccine. We'll continue to do that, and we believe that eventually people will gain more confidence, especially when they see that their leaders are taking the vaccines, when they see that their neighbors have taken the vaccines, health workers are taking the vaccines, then those skepticisms will be placed side by side with the evidence, and people will take the right decision. Now, in terms of what we're doing to get more than the 100,000 doses, again, the 100,000 doses of the Pfizer vaccine is a drop in the ocean, So we're not looking at the situation through rose-colored glasses. We understand very clearly that there are challenges to accessing these vaccines. The demand is more than the supply. The expectation is that, yes, we will get some vaccines from the COVID facility before the end of Q1, additional vaccines beyond the 100,000 doses. But we're also making efforts through the African Union. There is a task team, the African Vaccine Acquisition Task Team under the African Union, that's making overtures to get vaccines. Our understanding is that they've been able to secure up to 270 million doses of vaccines for the African Union. Nigeria has already expressed interest in acquiring some doses from that. So apart from the COVAX facility, we're having multiple engagements with African Union, with the Russians around the Sputnik V vaccine, with the Chinese, with the Indians. So all those options are on the table. We want to get vaccines as fast as possible to Nigeria, but the underlying principle has to be that these vaccines have to have passed all of the criteria that are required. So even before they are utilized, we're going to be looking at their certification by stringent regulatory authorities such as the FDA, the regulatory authorities of Canada, United Kingdom, that have already certified the vaccines such as the Pfizer vaccine. But beyond that, WHO certification is important. All of this information, along with the dossiers of these different candidate vaccines, will be reviewed by NAFDAC, Nigeria's regulatory authority on vaccines and biomedicals. So they will have to look at this data and certify that these vaccines are safe for use. So we're not focusing only on the COVAX facility. We're focusing on multiple options. The rate limiting step, the deal breaker for us has to be that they are fit for use in Nigeria as approved by NAFDAC. Putting the ultra cold chain equipment here. Well, this is our national strategic cold store. This is where we put all our vaccines, right, that come into the country, and it is strategically located near the airport so that immediately they are brought in, where our vaccines are kept in this strategic cold store. And we, as you can see, we have military around this environment, right? We have the army, we have police, we have the Air Force, and we have also done additional strengthening of the security around this place, just because we know that the vaccines, when they come, are going to be, highly, precious. They are going to be desirable, and we do not want any, mishap. The rural areas, how are we going to get data around the people that are vaccinated? So we're setting up an electronic registration of the health workers all over Nigeria. We already have the numbers of those health workers. We're going to be using our routine system. There's a system that we call DHIS2. That is what we're going to be using to register all of the health workers that are going to take the vaccines, so that in our database, we know who has taken the first dose, and they know exactly when they're supposed to come for second dose. But apart from the health workers, we are doing what they call a micro-planning. A micro-planning is a detailed plan around where people live, which facilities exist in different areas. We have high-resolution maps that show all of the settlements around in Nigeria. We use geographic information systems, right? GIS-based high-resolution maps from the Degree 3 project that Nigeria is involved in. Nigeria has used this same project for polio eradication programs, right? So we started polio eradication by using hand-drawn maps. So you come to maybe an area like the airport, and you use hand-drawn maps to draw where the strategic cold store is, where this house is, where this building is. But using GIS, we're able to use imaging to identify every single settlement, everywhere in Nigeria. And this is what we're going to use to plan how we'll reach each settlement, plan where we're going to be able to keep the vaccines in every health facility. So it is not just guesswork, it is based on years of working on the polio eradication program that we're going to use the same experiences to clearly delineate day by day, week by week, month by month, how many people we're going to be able to reach using realistic estimates. So it is not just assuming that we're going to, it's not kadu, right? It is really based on science. It's based on a plan. We have a comprehensive plan that we have developed. We have a manual, an operational manual that we have developed, and I can show this to you during the next PTF meeting, right? We have developed a comprehensive manual that describes exactly how we're going to do it, right? So it is based on science, and we hope that we're going to use this. Again, we're not overly optimistic of what we can achieve. We know that in this type of environment, there are huge challenges, but we know those challenges are there. We know there are risks. So we have the whole idea around risk is what? To present ways of mitigating them. So while we have these plans on ground, we also know that there are some, unknown quantums, like people who might say, no, we don't want the vaccines, or we react to the vaccines, we're not going to take it. We've made plans for those, right? But in the end, we're only using data to make assumptions around the number of people that we're going to meet. But the vaccines have to get here first before we reach the populace. In terms of the insecurity in some areas, in the past, like with the polio eradication program, we've worked with the military, we've worked with security agents to get vaccines to where they need to be. We're going to be deploying those types of lessons. We could not have been certified white polio virus free without the incredible efforts of the Nigerian military in the Northeast, in many areas where we could not send our health workers to go and deliver the vaccines. The military actually used their medical corps to deliver the vaccine in some of those hard-to-reach, insecure areas. The military was able to escort our health workers to some areas where there were issues around insecurity. So we're going to use the same plans. Again, we're not just making this up as we go. We're using experience from the polio eradication program, but we'll have to tweak it to align with the current situation of COVID-19, right? So the challenges are there. We acknowledge that they are there, but we're going to work very hard to try and get the vaccines to all Nigerians.
Thank you.
Thank you very much.
Thank you very much.
Thank you. We thank you, colleagues.
Okay. Thank you very much.
Very well.
What?